part? All of it?
Yes.
All of it. GTR is a vertical defect next to a tooth. GBR, there is no tooth present. Bone graft is then added to that site. So think about when you extract a tooth and oral surgery says to you, hey, are we adding bone or are we not adding bone? GBR is the addition of bone after the extraction has been complete. Make sense? Good. Now y'all got a good 80% of it complete. Who can give me the definition of a vertical defect? Come on, I mean y'all see it. I'm not putting up anything that's not seen. What is a vertical defect? Just define it. So when you define it like that, that can be vertical or horizontal. You get what I'm saying? Because if you tell me that it's going down to the apex of the tooth, guess what? I would just make a straight line down, right? So what would be a better definition of that? Yes, you.
Bone is not no longer parallel to the lateral crest.
So what are my landmarks that allow me to know that it's not parallel?
CJ.
The CJ, and what else?
The alveolar. Alveolar.
Pretty much. So if your CEJs are parallel to each other and you realize that your alveolar crest is going at an angle, then it's no longer a horizontal bone loss, right? It's vertical bone loss. So in this case, when you look at tooth number 24, the vertical defect is present on the mesial aspect of tooth number 24. In most cases in the past, we would have said extract this tooth because the mobility is 2. We cannot salvage this tooth. My probing depth is probably 10 millimeters. I don't know what else we could do for this area. However, what they realize is that if you add bone to this site, you can actually hold on to this tooth just a little bit longer. So now the prognosis of the tooth has become better. Instead of it having more or less a poor to hopeless prognosis, right now it is more at a favorable prognosis because we were able to rebuild the bone that's there. Most of you may be saying to yourself, well, why can't I do this with horizontal bone, right? Horizontal bone would mean that I would have to stack the bone on top of itself and hope that it stays. When you think about your, sorry for those of you that do not like a right leg, but when you think about so this is where our bone originally is, right? Now our bone has come down to here. You can't stack particulate bone. Think about particulate bone as being sand. You can't stack that on top of each other and expect for that bone to stay in place. Because essentially, there are no walls to hold or contain that bone. If you have a vertical defect, in thinking that again you have a 3-wall defect, y'all remember what your 3-wall defect is, right? Then you have at least 3 walls to contain this bone and keep it at a certain height. But when you look at this, horizontal loss is basically saying to yourself you have no walls present. Does that make sense? A little bit of sense? Yeah? Are you sure? Because I see most of y'all just still looking, figuring out your lives. Does it make a little bit of sense? Yes? Okay. So, when we talk about grafting a site, understand that not only do I want to know whether you can graft it, I'm expecting you to tell me what type of bony defect we have there. Vertical defect, how many walls would we have? Maybe 3 walls. Because I have a wall here, I have a wall here, and if you see this light transparency that's there, right? I'm just losing my wall here. So I still have a 3-wall defect. Again, drawing your box, your 3D box, and putting the tooth inside. You will see that. And in doing that, then you will say, oh, well, Doc, I think we can graft that site. Perfect. If we can graft it when we open it up, everything looks great, I will be happy to graft that site. Okay? Now, why regeneration versus repair, reattachment, new attachment? Well, regeneration is supposed to be the means of actually providing you the original apparatus. What is the original apparatus in the periodontium?
Bone, cementum, and aspiral ligament.
Okay, let's try that again. Daniel Pina. Let's try that again.
Cementum, PDL, and bone.
What else?
Tendon.
Cementum, PDL, bone. There's got to be one more thing. Which is your epithelium, right? You have to have those 4 things. Your epithelium attachment has to be present, right? It should be present, right? In order for you to have a sound periodontium. So when you are providing me your answer on your examination, and I ask you, all of these things are part of your part of your periodontium. All of those things should be noted. Epithelium, cementum, right? PDL, alveolar bone. All of those things provide support to that tooth. But when you look at things like your new attachment, your reattachment, and your repair, then you have to start asking yourself, what is the rationale between all of these things? So, when I look at it, what do I want to attach to the site first? Do I want my epithelium to attach first? How long does it take for epithelium to reattach to the site? I can't hear y'all. Because it's like right there. 7 to 14 days, right? I'm not giving you anything again that is not on the board, because I don't want to hear silence. How long does it take for my mesenchymal cells or my connective tissue to attach? How long does it take for my alveolar bone? 6 to 12 what? Months. And my PDL cells are 6 to 12 months. So when you look at it, if you think about all the stuff that Dr. Glasgow taught you in your basic surgery, it pretty much matches up, right? After doing any type of surgery, you expect to have your epithelial attachment going first. But when I'm trying to do regeneration, I don't want these epithelial tissues to go in first. Why? Because when those epithelial tissues go in first, they downgrow into the site, blocking my connective tissue, blocking my bone cells, and my PDL cells, thereby resulting in the most variable tissue in the mouth. Your epithelial tissue becomes not just your junctional epithelium, but your long junctional epithelium. Does that make sense? If epithelial tissue is given an opportunity, because it's the biggest bully in the mouth, if it is given an opportunity, it will block all of these cells from reattaching in its original position. So, we want to make sure that when we understand the types of healing, we understand it properly. What are we trying to achieve when we do regeneration? In repair, repair is basically after you have scaled a site for a patient. Your epithelial tissues will downgrow into the site, therefore just causing that reattachment. Again, increasing your probing depth. Does that make sense, everybody? Again, your junctional epithelium is no longer junctional, but now becomes your long junctional epithelium. I feel like y'all don't hear me. Yes. Kenny.
You said the probing depth would increase?
Yes.
If the long
Yes.
surrounding the site.
long junctional epithelium, for some odd reason, is actually not this strong. I wouldn't say it's the strongest attachment that we can have. So if you ever remember probing around in each other's mouths, you'll see 2, 3, 4, 5, 6. If you take into account of your biologic width, your sulcular depth is what? Oh, we definitely have to do this test again. The sulcular depth is what for your biologic width?
1.
Jesus. It's around that, yes. 0.69 to be exact. 0.69. What is your junction epithelium? I like how most of y'all looking at me dead in my face like her face is gonna give me the answer, and I know it. I know her face is gonna give me the answer. It's not. Sounds like we got homework to do. Because that is definitely a test question. Okay? When you look at your junction epithelium will be around 0.97. It's basically saying 1 millimeter. That can go all the way to 14 millimeters, 15 millimeters, 16 millimeters. Your connective tissue will drop down to the base of it, only being your other 1 millimeter. So that's why in a healthy periodontium, your probing depth should range from what? 0 to 3. Takes in your sulcular depth, your connective tissue depth, and also takes in your junction epithelial depth. Right? But when your probing depths start to increase from that 1 millimeter to now 14 millimeters, and you now probe, and your probe sinks and you no longer see markings, that is not your connective tissue. That is your junctional epithelium, which has now become your long junctional epithelium. When that changes, your probing depths will vary in the mouth. Hence, why it being the most variable tissue in the mouth. Y'all need for me to say that again? Yes. Okay, what part would you like me to say again? All of it? Yes, when you're doing your probing depth. If I ask you for biologic width, you subtract that 1 millimeter, right? That's all you.
That's where I was getting wrong.
Oh, yeah.
About identifying all of the sections. But I didn't know what I was getting all of the business levels right now.
Yes, when you are probing, you go into the sulcus, and especially if that area is diseased, you will drop down into your junctional epithelium, hitting the most coronal aspect of your connective tissue. Okay? But in a healthy periodontium, you basically should be able to say to yourself, I can drop down and get within my junctional epithelium, but not pass it and going towards your connective tissue. Does that help anybody? I don't know. What's the most variable? Junctional epithelium becomes what when it's injured? Long junctional epithelium. That is the most variable tissue in the mouth. Okay? So as you can see here, when you are looking at your epithelium has down grown into a site where we're supposed to have bone. Instead of your bone being there, your connective tissue has dropped down, and your junctional epithelium is now encompassing the site of your hair. Now our reattachment, I think all of you basically know that as when we're starting to do our flaps, we have our reattachment. That means that I do my modified Whitman flap or I do my Whitman flap. Once I do that full thickness or partial thickness tissue flap, and I actually replace that flap, those tissues will heal by reattachment. Okay? That's the simplest way to say it. Those tissues that have been lifted and opened up, once you close it back up, they heal by reattachment. So even now that y'all are learning all of these things, if I come back and I ask you what type of healing besides my primary healing, what other healing technique can be noticed in a flap surgery, you can tell me reattachment. New attachment, that pretty much kind of falls into play with everything else that we're doing. As those tissues are going back to the site, you're going to see again, your connective tissue is going to be a little bit more apical. However, those tissues are going to reattach as they originally were supposed to. Not necessarily in the original site, but they are going to reattach as they were supposed to. Sometimes you get a little bit of recession. Ankylosis. Ankylosis is not really understood fully because in ankylosis you have to say to yourself, how did this bone all of a sudden now get attached to this tooth? Was it through injury? Was it through any other means that this actually happened? But ankylosis does make it very hard for you to extract teeth. Okay? But in this fashion, you will see that the bone has actually attached to the tooth surface. External resorption. This now is when your connective tissue has now invaded that tooth surface, thereby causing what they look like almost like somebody took a bite out of that tooth root. This is your external resorption. It can be idiopathic. It can just happen for absolutely no reason, if y'all don't know what idiopathic is. It also can happen through blunt force trauma. Okay? That's what they say. And then, of course, your repetitive scaling and root planing. So, when you think about scaling and root planing, and I say, hey, Doc, how many times have you done this scaling and root planing? Oh, we've been doing it for the past 10 years. Well, now we have a little bit of resorption, external resorption of the tooth. So, it is always important to say, is it time for a surgical intervention so that you do not result in having that connective tissue bite into that root surface. And last but not least, your regeneration, which is our topic of discussion for today. Regeneration is when you have your equal parts of tissue that are now adhering to that root surface. Your epithelium, connective tissue, bone, PDL are all back in its original position because that is what you are looking for. So, now that we know what regeneration is, right? What is regeneration?
Reproduction,
Say it again, Cash. What is my original apparatus? The epithelium. Yes. Now, the next question in your mind should be, what type of bone do they use? You said that we use a bone that is a particulate bone. Sometimes it looks kind of grainy and sandy. Well, there are plenty of places in which you can actually obtain your bone. One is your autograft. Autograft basically means taking it from that same individual, your bone, replaced into a new site. That bone can be taken from an exostosis. What is an exostosis? Where? Where's your exostosis have excess bone?
On the buckle.
Tori is located where? On the palate or on your mandibular arch on the lingual aspect, right? Where's your exostosis?
On the buckle.
On the buccal aspect, okay? So you can use an autograft. If you have an excess amount of bone, whether it being your exostosis or being your tori. If you have a bone mill, you can grind this bone down and you see that you have a space in which you need to place this bone, you will use a autograft. Okay? Make sense? Allograft. Allograft is when you have dissimilar take his bone. I'm going to mill that bone down. I'm going to put it through a process. I didn't even take your bone. I won't take it. Okay? Mill it down, and I will make it to a point where it now can fit for Jonas so that we can grow bone in his mouth properly. Okay? Xenograft. Xenograft is what? Why are y'all laughing? Because I took bone from one person to the next. I won't snatch nobody's bone anymore in this classroom, okay? Look, it's just for example, not for real. I will not take your bone, okay? All right. What is a xenograft?
Different species.
It's right on the board, and I still can't hear y'all. What is a xenograft? From an animal, okay? What animal? Cow and pig. Understand that those are the only two. So if I put on that coyote, dog, cat, please do not pick and say, well, maybe. No. No. Okay? We are using either cow or we're using pig. Before you use a product like this, what are you supposed to ask your patient? Do you have any reason for me not to use a xenograft in your mouth? Okay? Just respect. Okay? And then you have your alloplast. Alloplast is more or less like if you look at a pumice stone, those ceramic materials, that is where your alloplast comes from. Okay? More than likely, what most clinicians have in their office will be your allograft. We have that here, we use it. Okay? And why? Because it is easy to use. I just take it from a bottle and put it inside of your mouth and watch it grow like a chew. Okay? Yeah, like a chew there. Okay? So, when you are looking at all of your bone grafts, already understanding the location in which you are obtaining your graft, because yes, a xenograft, I did say extra oral on there, so that also means you can take it from the hip. I don't know about most people, but Dr. Golden's shaking his head no, because he knows I was about to say, do you use that? Because I don't use that. Okay? Taking it from the hip is another surgical procedure that I will not venture into, but oral surgery at times does take bone from the hip in order to replace bone in the mouth. Okay? So, that is an option, but that's not an option for me as a periodontist. Allografts are what I'm going to use. Usually allografts turnaround time is 6 months to a year. Take that into consideration. What also heals in 6 months to a year? What? PDL and what? Bone. So if this turns over in 6 months, it's perfect timing for me. Everything is healing at the same time. I don't have to worry about looking at this bone 10 years from now saying, wow, you're still here. Okay? I want to find something that is going to turn over quickly. This is my freeze-dried bone. My mineralized bone. So right next to that FDBA, that is your freeze-dried bone allograft. Turns over in 6 to 12 months. Your mineralized bone, your DFDBA, that bone turns over in 8 to 12 weeks. So again, as a clinician, if I needed something to turn over quickly, I would be looking at that bone. But I still wait a little bit longer, maybe 3 months or 4 months before I decide to venture back into that site. Okay? So again, when you are looking at your allografts, you have 2 types of allografts. Your freeze-dried bone, which is your mineralized bone, that takes 6 to 12 months to heal. And then you have your demineralized bone, which is your DFDBA, and that takes 8 to 12 months to heal. Your xenografts, bios, like I said before, this takes a long time. There are a lot of times where you still see bios in the mouth, and that's because it turns over in a maximum of 10 years. Okay? Over 10 years, it is still sitting in the mouth, chilling. If I had to use any bone in doing any type of like sinus lift and I really wanted to see it and keep it there, that would be the bone choice that I would use. But I really don't like that bone because I still see the particulates. Okay? And then as I told you before, your hourglass or your ceramics. When you are, I want y'all to make sure that y'all look at the definitions of words as well. When you look at the definitions, these are the things that you are looking for in your bone graph. They are not here for you to just say, I know them and take it for the test. These are the things that are going on in your mouth as we speak, okay? As we speak, you are having all of these happen to you. Remember that your hips are a weight-bearing area. They turn over bone and break down bone almost every single day. So in that fact, it has osteogenesis, newborn formation all the time. Then you have your osteoinduction. This is the formation of new bone. And then you also have osteoconduction. You have to have something that is going to be your scaffold. Hold that space so that you do not have that epithelial downgrowth. Yes. It just tells you. Yes, it's a formation of new bone, but you also have to think what's in that new bone. That PDGFE, your platelet-derived growth factors, your BMPs, your bone morphogenic proteins, all of those things are your pluripotent cells. Those are your stem cells that help that bone turn over fast. Then you have, when you do your osteoinduction, you have less of those cells in that. Okay? But they're supposed to induce the formation. Because I know I have to get through both of these, and then you guys have a break next week. Y'all should be so happy about it. Then Dr. Steins will teach you, and then Dr. Buck will teach you. Y'all can see Dr. Steins on the syllabus? Oh, guys. Lies have been told already. It's too early. Y'all are telling me lies this morning. I know it's 8:30, but she's definitely on the syllabus. Now all of you gonna run the syllabus on the syllabus? That's nice. Okay. When we're talking about GTR or GBR, because there is a bony aspect that we've already discussed, there is also a membrane that is there. Membranes are used in order to block or impede that epithelial downgrowth. What they noticed is when they initially started doing all of this, is that they said, oh, we can put bone in here, but the amount of bone development or bone fill was less than 90%. Once they actually put the membrane inside, whether it be your resorbable or your non-resorbable membrane, they noticed that the amount of bone fill increased. Why? Because as we all know, epithelium grows in how long? How long does it take for epithelial downgrowth?
7 to 14 days,
Exactly. How long does it take for my bone to grow?
6 to 12 months.
6 to 12 months. So who do you think is going to win this race when it comes to my bone being in the site, it turning over, and then the tissues on top? The epithelium is going to win. So in order for me to say, hey, epithelium, relax, I got this, I need to put a membrane down, okay? And so the formation of membranes began. Now you have this as your barrier. There are different types of membrane. You have your resorbable membrane, which is the most likeliest membrane that most people are going to use, and then you have your non-resorbable membrane, okay? I'm only touching on points that I want y'all to know for your exam. Your non-resorbable membranes. When you are going through your PowerPoint, I want you to look at your non-resorbable and your resorbable membranes. Resorbable basically means that there is collagen present. Hence, it will turn over, the body will break it down, it will no longer be present in that 6 to 12 month time frame. That non-resorbable membrane will be present until you remove it. So, in saying that, yes, Chloe?
Can you run that back, please?
All of it?
Yes.
Okay. Resorbable membranes. Resorbable membranes have collagen. They are collagen based. 8 to 12 week time frame. Your non-resorbable will be present until you remove it. So that means that when you are using your non-resorbable membrane, that becomes a second stage surgery. Meaning that you have to find yourself going right back into the site, removing that membrane from that area, and then providing whatever procedure you want to provide after that, if there is a supplemental procedure. Good? Okay. So every time we talk about it, whether we have done soft tissue grafting or we're doing hard tissue grafting, you notice I always go back to the amount of walls that are present, right? So that means at some point in time on your examination, there is going to be a question about the amount of walls that are present. When you have a one-wall defect, is that favorable or unfavorable?
Unfavorable.
When you have a three-wall defect, is that favorable or unfavorable?
Favorable.
When you have a two-wall defect, is that favorable or unfavorable?
Favorable.
It's mixed, right? So we all like, it's favorable. No, that's a trick question. I'm not going to answer that one because I know she's going to give me this one. That one is pretty much in between. Sometimes that's a questionable prognosis. Okay? And I say questionable prognosis because, one, you have to look at the inclusion of the patient, how much the patient oral hygiene is, what their oral hygiene is like, I should say, and is that patient a compliant patient? All those factors will come in again. Yes,
So depending on what walls are made.
what actual walls are present in that area? Okay? So yes, you can have your buccal and your lingual wall because that will basically cover you from the compression of that site. So I would say that that would be helpful, but if you had just your mesial site and your buccal site, your lingual site, remember your tongue is right there all the time. So that is just a playing ground for that tongue to just sit there and play in that area. Okay? I am not interested in you telling me exactly which bone is osteoconductive, like the actual brand of bone is osteoconductive or osteoinductive or osteogenic, but I do want you to have an idea of the definition of those words. Okay? Okay. This picture right here is just giving you an idea of what happens when you have a cratered out defect. Okay? Everybody remember what a cratered out defect looks like? What it is? So by definition, you'll be able to tell me what a cratered out defect is? Yes? What is it?
Scooped out lesion.
For people that say yes. Go ahead, Kara, say it. Huh? But how does it look? I mean, the vertical defect or horizontal defect, they're all interdental, right?
Scoop.
Yeah, I expect for you to tell me that's a scooped out lesion, doc. It looks like somebody took an ice cream scoop and just said, swipe, this is my bone right here. So when you look interdentally, you can actually see in between 12 and 13 that it looks like a scooped out lesion. So in being that scooped out lesion, this is probably the most beneficial site that can be used in your grafting technique. So in GTR, I would say if I saw a scooped out lesion like this, I would be happy. Because I know I technically have all walls present, right? Because it's a scooped out lesion. I have my mesial, my distal, my buccal, my lingual. Scooped out just in the middle of it. So when I place my bone graft in the site, whether it be DFDBA or FDBA, my allo graft, right? When I put my bone graft right here, my particulate, and then I put my membrane on top, my collagen membrane on top, when I come back and look at the site, I expect to see bone formation in that site. But my bone formation will happen how many months later?
6 to 12.
Y'all notice I keep having y'all say it over and over again, right? So there must be a reason why I'm trying to get y'all to say it over and over. Because I want you to put that on every time you see the exam and I say, when is the bone fill? 6 to 12 months. When does the epithelium come? 7 to 14 days. So that way when you see time frames, I don't want y'all all look up in the sky and say, I didn't tell you, just like I didn't tell you Dr. Stein is what we teach you. Okay? So understanding the difference, I want you to know the difference between your resorbable and your non-resorbable zone. So knowing all of your resorbable versus your non-resorbable, I do want you to know, yes, you do.
How is resorbable membrane supposed to prevent epithelium from going over if it's resorbable?
What?
How is resorbable membrane meant to prevent epithelium from going over the bone if it's going to disappear?
Because that resorbable membrane actually takes 8 to 12 weeks for it to resorb. Remember, your epithelium basically is going to grow and stop growing, quote unquote, at 7 to 14 days, right? So once it reached that 2-week mark, it pretty much is stabilizing where it's going to be. That membrane itself is only supposed to say, I'm here, you're not going down to the base, I'm not allowing you to become long junctional epithelium. Okay? I do have a question that does ask you which one is resorbable, which one is not resorbable. So make sure that you have a look at that. Okay. And all of it, when you are looking at doing regenerative procedures, your regenerative procedures need to have P, A, S, S. It must be PAS. Primary wound stability. You need to be able to make sure that your flap has been approximated as close as possible and it is stable. You need to have angiogenesis. What is angiogenesis?
New blood vessels.
Rotation.
Blood vessels. Blood supply.
Vascular formation. Okay, so what's the other word for your vascular formation that I was talking about? Say it. Plasmatic circulation. I need to have my angiogenesis. Plasmatic circulation comes first. I have my angiogenesis. That means that all of my vessels have now reattached to each other. That means that I am getting all of the pluripotent cells that I need to have in order to have osteogenic bone growth. Okay? Then I have to make sure that I had my space maintenance. I need to make sure that my bone graft and my membrane are doing its due diligence in maintaining the site so that I do not have any defects in my bone once I go back. Stability. I need to make sure that my bone graft and membrane are stable with my flap and that the tongue and cheek are not going to compress the site. So when I look at it all together at the end of the day, all of these things go in my head as to what type of membrane I'm going to use, what type of bony defect do we have, do I have all the materials that are necessary in order for me to achieve my goal of regeneration. Okay? I know this is a quick review, and I apologize for that. Okay. Postoperative, all your postoperative instructions will pretty much be the same as the postoperative instructions you get for any other procedure, right? You tell the patient, please do not rush in the site, please do not smoke, do not drink, have a soft diet, nothing too spicy, anything like that. Please come back in a week to 2 weeks in order for us to assess the site and make sure that the site stays clean. Again, if your membrane or anything becomes exposed, especially your non-resorbable membrane, almost say to yourself, I'm going to need to abort mission because my flaps did not stay approximated. Now my site is going to have a lot of contamination, whether it be food or plaque, and my bone graft may not survive like how I want it to survive. Jonah, wake up. Okay? I know I'm boring y'all today, but I'm trying to hit through two things at one time. Okay? When you are doing GBR, what did I say happens when you do GBR?
It's after
After
extraction.
I'm sorry, say it again.
After an extraction.
Bone graft is added to the site after what?
Extraction.
After an extraction. Okay. I got 2 seconds to show you the picture. GBR. I've extracted the tube. Tube number 9. However, I didn't add any bone graft at the time. I go back in, and like anything else, as a surgeon, I want to now place an implant. But I don't have enough space buccally or lingually in order for me to do so. Now, I have to go back in and place a graft. If you see in G, that graft that is placed is not a particulate graft. That is a block of bone that has been obtained from another donor. That block of bone is now screwed into the site so that we can add more buccal depth. That is then also may also be covered by your particulate bone graft and a membrane and left to sit for approximately 6 to 12 months. Meantime, in between time, you are also going to have a false tooth in the front. After that time, as you can see, when you look at J and K, you have now obtained bony widths that will allow you to place an implant in the site of number 9. Now that implant is there, we wait another 6 months because the implant has to osseointegrate. Osseointegrate basically means that that implant and the bone must have a close approximation with each other. They must be intimate with each other, okay? Once that is done, then you will be able to restore that implant. Dr. Butler will go into that in a little more detail when he sees you for that lecture.
Or G, the extra bone that's placed there that remains throughout the entire process of using that.
I didn't hear a word you said.
I was saying for G, does that remain in place for the entire process? Is it like integrated with the bone, or do you use that?
Oh, the screwed in bone?
Yeah. Do you
Does that stay in place? Perfectly, it does. It is placed in that site, and when it's placed in that site, they have made sure that it is screwed tight in that space.
You don't remove it at any point; it just integrates.
You remove that. Now they do have some screws that are dissolvable as well. However, this screw, as you can see, is a metal screw. This screw will be removed when it's time for introduction. It will not stay in that place. Okay? Sorry for missing that step. But it will definitely be removed at the time. Now, in removing it at the time of reopening the site, do understand that when you are going to do your GBR cases, it is imperative that you are gentle in removing that. Because that is a titanium screw, and as we know, the body loves titanium. So it will adhere to that. So in trying to unscrew it, be as gentle as you possibly can, because I have seen it where people have removed that titanium screw, and that same bone graft that you added there goes with the titanium screw that you just placed. Huh? Yes, so we'll try try to osseointegrate as well, okay? So, when you are going over your GBR, my main thing for you to understand between GTR and GBR is GTR, a tooth must be present. A vertical defect must be present. Want me to say that again? With your GTR, you must have a tooth present. Just think about it. GTR, tooth. Tooth must be present because there is a T there. It must have a vertical defect. Okay? The best vertical defect I can have is a 3-wall defect or your cratered out defect. As the defect walls start to disappear, you need to say to yourself, my prognosis also starts to disappear. GBR is, again, when you have a tooth that is no longer present. All you have is bone. So when you're doing GBR, do not expect to have a PDL space. That makes sense to everybody, right? Very good. So if I put that on the test, none of you should say that the PDL is present. It's not going to be a trick question. All right? When you are doing GBR, again, you must be taking into consideration how many walls are present. Because as you take out a tooth, have any of y'all seen a person take out a tooth and also take out the buccal plate? No? It's very sad. Because now somebody has to fix it. Thank God for oral surgeons. Okay? You either take out the buccal plate, you take it out the hamular notch. All wonderful things can occur when you take out a tooth. Hence why there's no simple extraction. Okay? But after you've done your extraction, you assess the site. You place your bone graft in the site as you see in your picture. You'll place the membrane on top of that, and you will close the site up as best as you possibly can. In this case, you may not be able to have primary closure of your site. Remember, you have extracted a tooth. So the bigger the site, hence your molar site, probably the bigger the space that you have between the tissues. So in that case, you expect to see secondary healing in that site. I'm giving you hints to life. In your extraction site, you expect to see what type of healing? Very good. Again, possible test question. Okay? Go over both the GBR and the GTR. If y'all need more help with understanding it, please feel free to ask for a review session so that I can go over it again with you all. Okay? But the main aspects of GTR and GBR, I've given you. If you want to go look at somebody else's paperwork from last year that shows you the difference between all the procedures, that's on you. But my questions will be different from last year. Okay? So please make sure that you review everything. Ask me a question. If you want to ask it via email, ask it. Fine. But I'm going to put it out there so everybody knows what that question is, so I don't have the same question asked several times. Okay? All right. I hope that y'all have a great rest of your day. I'm sorry for the most ultra condensed version of this lecture series, but I hope that you got some